in the second webinar in our HR1 implementation series. We're going to talk about home and community-based services expansion opportunities that are in the law that was passed and signed this July 4th. So welcome, and we're really glad to have you with us. The chat is disabled. There's over 800 people signed up for the webinar, so that would be a little overwhelming. But if you have questions, please put it in the Q&A function. We'll try to get to those questions, but even if we don't, we'll be building out what we're calling an FAQ document, frequently asked questions for HR1 implementation, and putting that up on our HR1 page as well. So next slide, please. I introduced myself, she, her pronouns, I should mention as well, and I'm based out of Philadelphia. And Teresa, can you introduce yourself, my co-presenter here?
Yes, good morning or good afternoon, wherever you're at. I'm Teresa Tenori, and I'm part of the Northwest team for CSH, and happy to be here and welcome.
All right, and next slide, please. We've got an hour with you and a lot to do. We're starting with a poll. Tell us where you're joining us from today. A, are you in the Northeast? This is where I'd click. New York, Massachusetts, New England, Pennsylvania, our mid-Atlantic states like Delaware, Maryland. Are you from the Midwest, Illinois, Ohio, Michigan, Minnesota, the South, Southeast, Texas, Florida, Georgia, the West, California, Arizona, Washington, Oregon? Are you from a territory? If you're from someplace else, but tell us where you're from. And I believe someone is putting up a poll. It is not me because I don't know how to do that.
I think it's Kathy.
It's Kathy. Okay.
Mhm.
So yeah, tell us where you're from because we're sorry we have to disable the chat with this number of people in. Right. I'm not yet seeing a poll.
It's showing it's up on my end. People are putting it in. Maybe you
Oh,
guys
people are
just can't
putting it
see
in. Okay, cool.
Yeah, I'm so
I probably
sorry.
can't because I'm a panelist. So
Yeah,
awesome.
and I couldn't get off mute. I apologize, everyone. So far, 33% is in the lead, the West. 23 is second, the Midwest. Rounding 13% South. We have 1% in the U.S. territories and 2% in others. I cannot see the other at the moment, but
Oh, good. Oh, good. Welcome, welcome. We're really glad to have you with us.
we still, yeah, we still have a few people, so we'll give it another second. But the West is still in the lead at 34. Northeast is 27%, and Midwest is 23.
Right.
Okay, let's end this, and I will send this to you when we're all said and done.
Well, wherever you're coming from, we are glad to have you with us. So next slide. So today's agenda, we're going to talk about the key provisions of HR1 in relation to, here's an acronym. If you don't know it, you should learn it. Home and community-based services. We're going to talk about why home and community-based services is so critical to permanent supportive housing. Really is this S is in services that is part of PSH. We're going to cover a little bit about HCBS basics. We're going to hear from friends from Washington State who've done a lot in order to expand home and community-based services to people experiencing homelessness and using it as a critical tool for their state to increase their development of permanent supportive housing. So we're going to give you some basics here, help you understand that, and then we're going to tell you how you can take action because every state, this is a Medicaid program, home and community-based services. So people are going to ask questions and the answer is going to be, tell us what state you're in. I will ask that if you use the Q&A function, if you please tell us what state you're in for that when you ask that question. Maybe we'll get to some of those questions. I see people raising hands as well. We don't have time to call on anybody or take people off mute, etc. So I apologize for that, but please put your questions in the Q&A and we will either get to them at the end if we have time, or more likely we won't have time, but we will get to them on our FAQ page as well. So next slide, please. So our learning objectives today, we're going to talk about how Medicaid, that state and federal health insurance coverage program, covers home and community-based services and what changes the federal law, H.R.1. You may hear it called OBBA, the One Big Beautiful Bill Act. You may hear it called the Budget Reconciliation Bill, but it made a lot of changes to Medicaid. And in particular, it made some that we're going to focus on today around home and community-based services. And we're going to talk about, particularly hear from our Washington State friends, about ways to work in partnership between supportive housing and HCBS. by sharing some cross-sector approaches here. But a lot of this is going to give you the foundation and the basics to understand HCBS and to engage around HCBS services in your state. And we'll tell you why that's important coming up next. Next slide, please. So CSH is doing a lot of material and putting out a lot of information about H.R.1. There are many, many aspects of H.R.1 that impact Medicaid. There are aspects around work requirements. There are aspects around address verifications. There's Rural Health Transformation Fund money that's out there. There's a lot there. CSH has put together and is starting a blog series on this. This is our initial of all the H.R.1 Medicaid changes. Here's the 8 pieces that affect you, impact your agencies, etc., impact the people that you serve. We're putting out new materials every day. We also have a website that will have this recording, the slide decks here. First question is always, yes, we will send out the slides. Yes, we will send out the recording. Yes, we will send out the FAQ as we write it, and please stay in touch with us. So take a look at this link here if that's possible as well. Next slide, please. So why are we concerned about home and community-based services? That may be a term, HCBS, that's new to you, but it really shouldn't be if you're in the supportive housing business and you're looking for your state to cover Medicaid. If you've ever been in a CSH webinar, you've seen this slide or some variation of it. Medicaid is, supportive housing is a commonly thought of as three-legged financing stool. You need to create new supportive housing in your community, to sustain supportive housing in your community. You need capital to build the building, to keep the building up to speed, up to code, etc. You need operating funds, which is funds to keep the building going over time so that you don't have to charge significant rents. You want the building to be affordable to people with low or extremely low income, no or extremely low incomes. And then Medicaid for services. Medicaid for services financing is the critical element, not 100%, but a critical element in covering more and more services budgets in supportive housing development. So next slide, please. And if you're looking for Medicaid to say, okay, here's where we're going to cover supportive housing services, they've actually done that. They did that in what's called CMS. That's the Federal Medicaid Center for Medicaid and Medicare Services. They did this in June of 2015, an informational bulletin where they said, you know what? Medicaid has covered what you folks call supportive housing services for a long time. They've covered it in a program called Home and Community-Based Services. They see this as an HCBS service. So next slide is going to give you your states and where your states are in regard to these services, etc. But what's critical to know, thank you, Teresa, is whether my state is using what's called in the Medicaid space a 1915I or you're using an 1115 waiver. However your state's doing it, it's structured like HCBS. It's structured, set up, how you qualify for it, how you maintain those services all the time, how you as a provider get paid for those services, all falls into HCBS. If your state's in here on purple, your state's currently covering housing-related services via Medicaid in some way. As I said, maybe it's a research and demonstration or an 1115 waiver. Maybe you're Kentucky, DC, Minnesota, and you're covering it via your 1915I state plan amendment. Maybe you're Nevada and you're covering it via an in lieu of services. Don't have to understand that. What you need to know is that your state is covering housing-related services, tenancy support services in some way. They're using it by Medicaid. You want more details there. We've got a link to our map. We've got a link to our updated summary document there, etc. And next slide, please. So H.R.1 impacted Medicaid in many, many different ways. H.R.1 is showing almost $1 trillion in cuts. Current analysis says that about 7.5 million people, that's million people across the country, because of H.R.1 are going to lose their health care coverage. They're going to lose their health care coverage because they can't negotiate work requirements. Maybe they're not working. Maybe they are, and they can't figure out the system. Maybe they're going to get caught up in the address verification process. Many, many different ways. That's not what we're here to talk about today. What we're here to talk about is the HCBS piece, but know that H.R.1 has major changes coming in enrollment and eligibility, how your state Medicaid enrolls people, how they maintain them and keep them eligible, and then how they pay for services. $1 trillion in cuts means $1 trillion less going into state budgets, and we know these are going to be. We know fiscal year 27 is just going to be the worst budget year in state budgets for a long time, which is why we really want to educate our field in order to advocate for coverage of these services, and we want them to understand this HCBS opportunity here. So think about it in two ways. From H.R.1 is for the individual person, how do they enroll? How do they maintain eligibility? That's going to be getting a lot harder in the coming months. And then finally, finance and payment. States are going to have a lot less money. States are going to be looking to cut. It's going to take advocacy to maintain that map we just showed you. 31 states are covering tenancy-related services. We want that number to go up, closer to 50, not down. But that's going to be really hard because of how much less money states are taking in. So next slide, please. And as Teresa starts, I'm going to get into the Q&A and try to answer your questions. Teresa, over to you.
Thank you. So as Marcella said, lots of changes coming with HR1. This is just a reminder about the two paths into Medicaid. It's good to remind ourselves that there's two ways individuals qualify for Medicaid. One is through a more traditional way. It's been a long-term way, is through their aged, blind, and disabled pathway. The other is the expansion group. So HR1 had the most impact on the expansion group. Expansion group came about through Obama at the Affordable Care Act and include the more individuals that didn't qualify under the disability piece, but other ways they qualify. So what we want to highlight here is that a lot of work is occurring now to find out if you're a housing provider, if your tenants are qualifying for Medicaid through this expansion pathway, is to start getting ready. You know, for instance, you know, do they have a disability? Could they go through the Social Security door to qualify? And it's a time to evaluate that and to see if they don't, do they qualify through the exemption group? All the changes in HR1 are now in statute. We know that those particular changes now are a part of the Social Security Act, Title 19, and they are law now. So those exemptions, for instance, are in law. It's just an important way to kind of highlight these changes that are coming about and are part of our new landscape for Medicaid. Now back to you, Marcella. Oh no, me. Sorry. So what did HR1 do for home and community-based services? And we're going to get into more detail on this, but just know that it eliminated that level of care that all home and community-based services throughout the country rely on for eligibility. It's called the nursing facility level of care. Basically, it is that an individual's needs are the same as if they would qualify to go into an institution or in a nursing home. A traditional nursing home. And that's how the waiver for home community-based services started. It's one of the oldest waivers in our country. It's been longstanding and really proven to be a very cost-effective and worthy waiver in the services. So this change by HR1 eliminating the NFLOC, or this nursing facility level of care, it allows states to redefine an alternative eligibility criteria for home and community-based services. The implications are great. It kind of expands access. It could be more preventative. So a person doesn't need to be as needy or need that level of service before you can get services to them. It provides more state flexibility for states to come up with some new criteria. And of course, as Marcella said, this is in light of all the budget pressures that states are going to be facing that are real, definitely real. The issue, though, is, what are their alternatives? And so we're going to paint some more information here about home and community-based services to get you thinking about this other way to get some services to individuals. So your turn, Marcella.
Thanks.
No, mine again. Sorry.
You're okay.
Yeah. So understanding the why of home and community-based services. So what are the tenets that kind of make home and community-based services what they are today? They support and care in people's homes or in community settings rather than institutions. So the waivers that really created home and community-based services were built around people could thrive and be healthy in their homes as opposed to nursing homes. And that has been true. In our country, we have more, economically, we are investing more in home and community-based services than in nursing homes. And I think that change occurred about 2013 in terms of investments. They want to maintain independence and improve quality of life in familiar surroundings. We all know people want to be at home or in places where they're comfortable, and they want to spend the rest of their lives in those settings. So it doesn't mean that they don't need higher levels of care when they need it. We all might need it someday, but this is furthering their independence for as long as possible in their home. And it also was specific to clinical populations. The home and community-based services allowed states to define which populations can get served at home. And that varies by state, but it's still very specific to clinical populations. And then, of course, the last pillar here is reducing the reliance on costly institutions. And I think we have, as a country, has kind of proven the economic worth of having services in your own home and for as long as possible. So be less costly. So now back to Marcella. Oh, mute.
Thank you there. I was talking in the Q&A. Good back and forth in the Q&A, folks. Again, other questions, because we don't have a chat right now, but please jump into that Q&A and we will be there. So let's start at the foundations of home and community-based services. Home and community-based services are a part of a larger Medicaid program, which you also hear called long-term services and supports, or LTSS. There are two aspects of Medicaid's long-term services and supports program. One is nursing homes. That's mandatory. Nursing homes are one of the things that the feds say your state Medicaid program has to cover nursing homes or you don't have a program. That's required of states. Unfortunately, home and community-based services are what's called in the Medicaid world optional. It means states can do it, they don't have to do it. All states have 47 states we're looking at here, but probably I believe most states have some kind of state plan amendment or waiver, 250 plus waivers. You'll often hear it called the waiver program because this is what came first, but really it's a larger home and community-based services program. There are two authorities, Medicaid authorities, that you commonly see. They're not the only ones, but they're the most common ones you see. First, you saw 1915C, that, as Teresa said, has historically required a nursing home level of care. Nursing home level of care can be as simple as a person needs assistance with at least, Teresa, correct me if I'm on this wrong, you taught me this one, 3 what's called activities of daily living, or ADLs. Every day we have to get out of bed, we have to feed ourselves, we have to brush our teeth, we have to bathe. These are all activities of daily living. If I can't do these things on my own, then I need some kind of assistance. People are looked at as possibly being nursing home level of care when you have 3 or more ADLs that you can't do on your own. So these are 1915C waivers. They're waiving certain aspects of the Medicaid program, but that's going to be changed under this change in H.R.1. There were also 1915I, what are called state plan amendment services. These are also coming under HCBS, tenancy support services, right now in New Hampshire, in DC, in Michigan, not Massachusetts, Minnesota, are all covered under the 1915I state plan amendment, etc. So know that. The authorities aren't really important. What's important to know is who's the network, who runs the network, who allows these services, and what our funding for those services are. And we're going to talk a little bit more about this. But you're part of the LTSS program. When you start having these conversations, you want to know some of the lingo here. Additional criteria for new HCBS authorities under H.R.1. So here's what's changed. States can now, the feds can't approve anything until 2028, but states are looking at this already. They can request a 3-year waiver. They can request over a 3-year period defined in H.R.1, a 5-year waiver. So over 3 years from 28, 29, and 30, they can request 5 years of coverage of HCBS services. Again, the feds can't approve anything until July 1, but states will be looking at this long before that. They'll be looking at it for populations who they'd like to get out of institutional care. We may see this come up as we talk about what are the services for people in encampments or the institutions that this administration is talking about building, etc. So a lot of this will be one of the services tools in the toolbox. We really want to understand this for our field. The average wait time can't be increased. There's a lot of concern in the HCBS world, since this is something you don't usually hear in the Medicaid space, that there is a wait time. 1915C waivers, one of the things they waive is that you're going to have a wait list. So it's critical to understand how long is your wait list, who does your state cover, and they can't, in these new waivers, they can't have a longer wait list on average than any other, than any of the other waivers the state has. The state has to establish a needs-based criteria that's no more stringent than the current criteria. They can't say, oh, we're only taking people with 10 ADL problems, etc. We used to do 3, now it has to be 10. They can't go that way. They can go down, they can't go up. So states have to establish that need-based criteria on there. And the benefit has to be cost neutral. So if it costs $100, I'm making up numbers for easy math, for somebody to be in an institution, it costs thousands, not 100. You can't have that number go up. So it has to be cost neutral to the feds for average per capita cost of the individual receiving institutional care. That's usually the case and easy to find. So most state Medicaid offices have a small group of people who are really expert in HCBS. Met some really, really wonderful people in this space. And these are the folks you want to find in your state and say, what are we looking at in regard to these new HCBS authorities and opportunities? Is my state covering HCBS? Tendency support services under HCBS, can my state cover it? But I'm jumping to action. Sorry. Next slide, please. So also to help you understand what's involved in an individual accessing HCBS, you're working with a person who's unsheltered. They're in your supportive housing program. They're in your shelter. They're in your transitional or rapid rehousing program, and you think they would benefit. They've got trouble with those activities of daily living, managing them on their own. You think HCBS would help. What do? Well, 1, you've got to make sure they're enrolled in Medicaid in your state. 2, you've got to find, Google is your friend, who does the assessments for different waivers or state plan amendments or HCBS in your communities. It's done by the state. It may be done by state officials. It may be done by state defined groups, but it's a very narrow group of people who can do these assessments. Assessments are both financial. They have to qualify for Medicaid, so they have to be extremely low income. It's diagnostic. They have to have the state may have diagnostic criteria. Now that can be as simple as they have to have one chronic health condition and they have to highlight those functional limitations. Again, doesn't have to be 3, can just be 1, but what can people not manage that they need these services in order to maintain in the community? And this assessment that happens for eligibility determination for the HCBS happens once a year. When you have the assessment that says, hey, Marcella can't do these things, they're critical to daily living, we think she's going to qualify for HCBS, then what's developed is called a person-centered plan. Similar general principles to a treatment plan or a recovery plan, or just what are we all doing here? How are we all working to support that individual? Somebody in the chat already asked about conflict-free case management, so I'll mention that there. Case management, it's not, if you come from the homelessness world or the behavioral health world, it's not how you think about case management. It's really a care coordination referral service, making sure that person is referred to all the services they need in the community. But it's a lot on the person and their natural supports to get them there. The caseloads are too high to do that sort of, hands-on work with people to move them there. Conflict-free means whoever does the assessment can also be delivering the services, which is why the states have these very narrow windows of who can do the assessments. You as a supportive housing provider may want to focus on delivering the services and figure out who does the assessments and get referrals from there. It's a service coordinator like role. The person-centered plan says, okay, what are all the services Marcella needs in order to maintain in the community, not to go into the nursing home, and how do we get her referred to these services and systems? And that plan needs to be updated at least annually. The care coordinator or the case manager is what's often called in this space, tries to make sure that the individual is receiving all these services. But if they're not receiving the services, mainly what they do is kind of call the people who are supposed to be delivering the services and say, hey, what can you do? There's a hands-on piece that it isn't as I said, I come from a behavioral health and homelessness background. I'm used to 1 to 10 caseloads of administrative committee treatment team. It's not that. It's referrals. And then once you have a person-centered plan that says Marcella needs tenancy support services in order to maintain in the community in her housing, then you get to service delivery. Then you hope that your state is covering housing or tenancy support services there, etc. Supportive housing providers, agencies may partner with other services. Regularly, you may partner with the agencies that do the assessment so that you can get the referrals. You may partner with other agencies that deliver this to other services. You may say, you know what, we're not going to do nursing home care, and we've got not nursing home, but skilled nursing care. We're not going to do personal care. We're going to hire other, we're going to work with other agencies. That's your call to see what a person qualifies for based on their person-centered plan. And then either it's maybe something that you deliver, or it may be something you may have partners deliver. So there's the eligibility determination process and assessment. There's the person-centered plan development process and assessment. And then there's the actual service delivery. The term conflict-free case management means that it's a different entity, not a different person, but a different entity. One agency can't do all these three places, all these three activities. In particular, person-centered plan and service delivery have to come from different agencies. There are exceptions of that. There are provider shortage areas, for example, in rural communities. There are cultural exceptions for that. You may be working, say, with a Native American population, and there isn't any other Native American providers that do that. But generally speaking, conflict-free case management is a requirement. Next slide, please. And I see lots of Q&A. I'll have you get back into that. All right. I will hand this back to Teresa to talk about what are the other common HCBS services that your state may be offering.
So as Marcella said, once that assessment is done, particularly that functional assessment and the financial assessment. Functional assessment is really tied to what we talked about earlier, the NFLOC, that nursing facility level of care. That's going to tell the state what level of care or what kinds of services are needed for this person. So this will vary by state or even by county in some jurisdictions, but personal care assistance is that, any kind of assistance they may need that were assessed and identified by a separate person from service provider, what kinds of personal care services they need. Home health care can also be provided in their home. So that's, nursing coming into their home. It's occupational therapy, physical therapies, respite care for caregivers, a lot of support for the caregivers in their homes, transportation, meal delivery, which is very common to see, case management or care coordination. And here, it's really for the service provider. So to me, this reminds me of tenancy sustaining services that we see in a lot of the 1115s, is that type of work that's done in housing facilities that connect people to services, check in with them, make sure they're getting the services they need, and arranging for that. So that's kind of that type of case management, separate from the person doing the assessment. Environmental modifications, anything that's needed in the home, assistive technology. Also, if they're doing virtual visits, some of that can be paid for by Medicaid and provided to the individuals. Services that secure and maintain housing. And we're going to hear from partners in Washington State about what that might look like. And then finally, some behavioral support services that you could see in home and community-based services. So those are the services, but again, it varies by state, and states will designate this kind of service package that goes with the population. Next slide, I think, it goes to our partners in Washington. So I'm going to invite our Washington partners to come on camera, if they can. We've asked them to join us because I think it's this great example of how housing services are part of their home and community-based services in Washington. Coming from that state, I almost took it for granted that we had these kind of services available. And it started with GOSH, which is the Governor's Opportunities for Supportive Housing. And I think, Audrey, are you with us today? Okay. if you are, maybe you can unmute yourself, maybe. Anybody from Washington want to join us? Oh, raised hand. Yeah. There you are. Can you come off mute, Audrey? There you are.
Thank you. Yeah, can you hear me now?
Yes, perfect.
Okay, great. Sorry, I wasn't able to interact previously.
That's okay. Thank you for joining us. We asked our partners in Washington for 3 questions. And so Audrey, why don't you start us off with how did it start? I know it started with GOSH, the Governor's Opportunities for Supportive Housing within Home and Community-Based Services. And now it's called the Office of Housing and Employment. How did it
Yeah.
start?
Well, so back in 2016, the Washington State Legislature enacted as part of a behavioral health transformation project some funding for what they call the Governor's Opportunity for Supportive Housing. So this was an allocation of our state general funds to help provide supportive housing services and a state-funded housing subsidy to individuals who are exiting our state hospitals. So folks who were experiencing involuntary treatment stays for mental behavioral health at our state hospitals and re-entering the community. That started with funding for 15 people, and the program has grown since 2017. We have a team of 6 full-time staff who work with the GOSH program, and we've been able to expand eligibility to include folks that are experiencing involuntary treatment holds at hospitals out in the community as well. And that program is still going really strong, but it now falls under what we have as our own Office of Housing and Employment at our Home and Community Living Administration at the state of Washington. So we now have several other housing related programs that we can refer our long-term care clients to, including eviction prevention, motel stays for transition. We have several set-aside units. We have a couple of staff whose job is to partner with housing providers throughout the state and secure set-aside subsidies and units for our long-term care clients. So we have quite a few programs now to support the housing needs of our long-term care clients. With GOSH in particular, we contract with supportive housing providers throughout the state, and they provide the individual, one-on-one services from the time of referral, so they can begin working with folks even while they're still detained and receiving treatment. They can begin working on their housing assessment and identifying what kind of housing they would like to move into out in the community. And if housing is not secured by the time clients are discharged, then we're able to use one of our long-term care residential settings, like an adult family home or assisted living, as a temporary interim placement. So while the housing search is underway, we can keep folks moving, let them discharge from the hospital and re-enter the community.
Great, thank you. I think you covered that second question. What about the partnership? You actually touched on this, but anything else you want to share about that partnership between home and community-based services and supportive housing providers?
Yeah, well, the 2 main ways that we connect our long-term care clients with supportive housing services is through the GOSH program. So those are clients that are directly receiving, that one-on-one support with the GOSH providers who are contracted with us directly. We also do work with our Washington State Healthcare Authority and a third-party administrator, and refer folks out to foundational community supports. which is an 1115 waiver supportive housing program paid through Medicaid. So we don't contract directly with those providers, but we do have a partnership in referring out to providers in the community for our clients who need those supports. Of course, the billing and authorizations are not done by our long-term care team. And then our other programs are primarily financial supports. And we do have some contracted providers who work only to help make payments and things like that. So if we're providing that eviction prevention assistance, there are some providers contracted throughout the state that will just do the transaction of paying that back rent and then be reimbursed through our program.
Thank you. What about the work that you do with the housing authorities? Can you speak to that?
Well, as a part of the governor's opportunity for supportive housing, and a couple of our other programs, we do have state-funded subsidies. So we mirror those subsidies after the housing choice vouchers at the federal level. The idea being that our subsidies are not time limited, but they are temporary. We encourage folks to eventually be working towards securing a permanent federally funded housing voucher. But we've been able to contract with one of our housing authorities in the state of Washington. For us, it's the Spokane Housing Authority, and they help us manage those subsidies statewide. They help with inspections, coordinating all the paperwork, and again, they mirror all of the, from the time of application to move in and annual recertifications is all mirrored after the housing choice voucher, so that when folks are able to secure one, it's a smooth transition.
Great. Thank you so much. I think it's a great example of how you have really worked to support housing within home and community-based services. So I'm sure if we have any questions in the Q&A, we'll send them your way. So folks have any questions for Audrey or Washington, that'd be great. So thank you, Audrey. If there's anything else you want to say before we move to the next slide.
Thanks so much for having us. I think we are really lucky to have a lot of support in our state, recognition of the importance of housing people and the foundational impact that has on folks' health. So yeah, I feel we're grateful to have that support, but we do have a lot of data to show the success of the program. And I would encourage anyone who's interested in learning more about how we've built out our team and the programs we have to feel free to reach out to us.
That's
Thanks for
great.
having us today.
I'm seeing lots of hearts and clapping hands coming your way. So that's great.
Definitely. Teresa, I've got two questions from the Q&A that are really Audrey questions. Can I jump in and ask them if that's okay?
Absolutely. Yes.
All right. From Amy Hansel, Audrey, does GOSH support individuals who are transitioning from state institutions or inpatient behavioral health programs? Do they support individuals with autism or similar IDD, or is it just mental health?
So the key for qualifying for the GOSH program in particular is that there has to be a court-ordered treatment in place. So the program can work with anyone experiencing any type of diagnosis. The supportive housing program is not the behavioral health provider. So those supports would be added on and we can help coordinate that. But there does have to be an involuntary treatment order in place for that program. We do have other folks accessing our state subsidy though, through a program where they are exiting a skilled nursing facility. So that is another pathway to access our state subsidy that doesn't come with the supportive housing services though that the GOSH team provides.
That's awesome. Thank you. And a second question from Sam Oppenheimer. Where are you in Pennsylvania? I want to learn that, Sam. She wants to know, how does HCBS in Washington compare to foundational community supports? Foundational, for folks who aren't Washington savvy, foundational community supports is what Washington State calls tenancy support services covered by Medicaid. So Aubrey, talk to us about HCBS and FCS and how they do or don't work together in your experience.
So we partner with the FCS program. Anyone that is on our long-term care services meets that first eligibility criteria for FCS, which is needing that assistance with 3 or more activities of daily living. So anyone that comes to us for supportive housing services is partway to meeting eligibility criteria. They do also have to meet another, what they call risk factor criteria. So not all of our long-term care clients are automatically eligible for FCS supportive housing, but they are part of the way there. And we work with our healthcare authority team to help guide the program and provide feedback and input, and we're a referral partner out to FCS, but we don't at the state Home and Community Living Administration, we are not contracting directly with FCS providers, so it's more of a partnership kind of at the top level to support and help guide the work, but we are basically referring as a third party when we make a referral to FCS for our clients. But we do then stay in touch and coordinate with the FCS provider and the long-term care case manager, partly because our clients often qualify for transition supports like moving costs, getting set up with basic furnishing. So if we're referring a long-term care client to FCS, we try to stay in touch and coordinate all together so that we can add those additional resources in to support the FCS providers' work.
All right, and here's another question, always a smart question from Margaret King. What is the billing structure for GOSH utilization?
Yes, the billing structure is, we have 2 types of billing. So we have a pre-tenancy billing structure that's from the time of referral up until we typically will wait 90 days after a client's moved in. And that provides what is it? 160 units at 15 minutes. My math could be a little off. It basically authorizes 40 hours a month of provider time in supporting the client in anything they need for their transition, housing search, getting set up on whatever supports they need in the community. And those are billed in 15-minute increments. And then after the client has been in a tenancy for 90 days, unless there is a complex, situation, at which time we can go back to that more intensive billing structure. But after that, it's a monthly flat rate for providing a lower amount. I think it's only one in-person. Well, there's sort of a tiered down requirement, but eventually long-term, it's just one in-person visit required per month, as well as a couple of check-ins. But it does go down to that lower level of support long-term.
Right. All right, let me look at, I'm still doing, let's see, just a couple of more questions here. We have someone from Michigan, housing supports and eligible service under their behavioral health carve out. But yes, it is separate from home and community-based services because Michigan has the carve out. And then would HCBS funds to be able to use for cost of tenant education classes, tenant readiness courses? Generally speaking, no. Remember, any Medicaid service is not going to fund a class for any random amount of people. It is going to fund a particular individual. So it can fund it can fund somebody who supports an individual like Marcella in tenant education and tenant readiness, but a class, which we know would be a more efficient way, you'd be able to serve more people. I don't see that. There may be some possibilities. You're from Oregon, they're awful flexible there. So I would reach out to your local coordinated care organization and see that is there. There's lots of possibilities there. And Enrique, hey Enrique, have you seen states limit what can be covered and by whom? We haven't seen that yet. We do expect to see that with really, really tight state budgets, and that's why we want to get good information out to as many people as possible. I think with that, I'm gonna let Teresa keep going here, or maybe back to me. I'm not sure.
Yeah, I just want to thank Audrey for joining us and providing that information. It's really valuable to know and to hear your experience there. So with that, thank you very much. And I think I'm passing it to you, Marcella, to close us up. Thanks.
All right. So next slide, please. And thank you, Audrey, as well. I love hearing about Gosh. All right. So you've learned a lot here. You've learned home and community-based services. I've been back and forth with a number of you all in the chat. There are great questions there. You've got good ideas. What can I do this? Who can I do it for? How can I do it? The detailed questions you want answers to are really a state-by-state conversation. If your state has a CSH crosswalk, a CSH Medicaid crosswalk, we can answer those questions for you. We have crosswalks. I live linked to the chat for somebody who asked about Idaho. We've got crosswalks for Montana and Oregon and North Carolina and a number of other places. We're finishing ones up in Illinois and Kentucky right now. But they're detailed questions, and you may want to connect to your local CSH or CSH office in order to try to find that. What should you do now? You say, hey, there's this thing called HCBS in my state, and I've got people who I'm working with every day with people who have trouble with activities of daily living. How do I connect them to HCBS services? How do I make sure that housing support services are covered? Engage with your state coalitions that are working for better access and better care for Medicaid recipients. If your state hasn't expanded Medicaid, if you're in Texas and Florida and other southeastern states or Wyoming, there's a coalition working in order to expand Medicaid in your state. Find those people, meet them, align with them. They know how to have this conversation. If you're in one of the other 40 states that has expanded Medicaid, that coalition has probably morphed from pushing for Medicaid expansion, which they obviously were successful. They're one of the 40 states that have expanded it, to making sure that everybody is covered and is continuously covered. They don't usually work or think about housed or unstably housed populations. They're starting to, and they need your knowledge, their support. They need the people. If you're a person with lived expertise, they need your story. So engage with those state coalitions that work for better access, for better care, see what they're pushing for. They're coalitions, very well organized coalitions, particularly in the IDD space, around ensuring services, ensuring access, getting that wait list down, etc. Engage with your state Medicaid office. Find out who in your state Medicaid office is advocating for new waivers and services, making sure that homelessness and housing instability can be one of the factors that contributes to that. These waivers will include diagnostic criteria like a health condition. They'll require ADLs, but they can also require social conditions as well in here. Make sure that that social condition is part of that, so you make sure that you can get the folks the services, you can get to the services for the folks you need. Help your state identify with data. If you're an HMIS manager, et cetera, how many people do you think qualify for that are in that? What data do you have that can support efforts to say that your state should cover the services? And if your state did cover these services, you'd keep these people out of institutions, you'd save the state money. Help the state with accountability measures also to ensure quality services and prevent waste, fraud, and abuse. And then monitor what CMS is doing, what your state is doing. We expect that maybe in the next 2 to 3 months, we will see more guidance from CMS in regard to what they're looking to approve here. There's new funds in there under HCBS, but the state still has to come up with a portion of state money as well. And that's going to be a hard sell in the next 1 to 2 budget cycles here. So find out how that works and engage with your state on those issues. And when I say engage with your state, I mean a couple of things. I mean your governor's office, I mean your legislature, and I mean your state officials in the state Medicaid office, your state HCBS leaders, etc. And a lot of those state Medicaid coalitions can really help you identify who are the people, what are they looking to add and change, etc. And so next slide, please. We are coming to the end, I believe. Thank you all for joining us. As we said, this is part of an ongoing series. Right now, we've got a tentative date of November the 18th. We're going to talk about Rural Hospital Transformation Fund efforts that are part of the H.R.1. We have upcoming sessions on work requirements, upcoming sessions on state Medicaid budgets. Remember, as Teresa said in the beginning, that we've got a lot less funds. States have a lot less funds to work with. So we want you to understand the state budget processes, etc., and stay in touch. And we will also send out, CSH has a website where we're putting all of these materials, etc. So thank you. If you have any particular questions and answered, give us a shout out at health@csh.org. All these other different ways to stay in touch with us here. New blog posts will be coming out on our LinkedIn. They'll talk about the more frequent eligibility determinations requirements, how important that is. When somebody asked a good question about how do we know who's ACA and who's not, that's tough and it's important to figure out because a lot of these new challenges are going to be falling on the expansion population. Work requirements, more frequent eligibility determinations, cost sharing or premiums, basically having to put some money into healthcare when somebody's got an extremely low income. So yeah. Teresa, what did I miss?
Think we got it. Yeah.
Oh, we've got lots of questions. Things came in the chat. Let's see. Let me see what I can answer here. What are the differences? Oh my gosh, that would take a whole webinar in itself. Differences between HCBS, Behavioral Health Connect, and CalAIMS Community Supports. Someone from California is asking us that question. Again, could be a whole webinar. What I think is really important in California is the person that you're working with or people that you're working with in your program, find out and know who their managed care plans are or what we call MCPs and reach out to them and say, this is what my person needs. I'm hearing about all these different things, BH Connect, HCBS, CalAIM, community supports. How do I get them what they need? And managed care should be working with you there. So hope that's helpful. Really quick answer, but stay in touch. Okay, state examples of capacity building. State budgets only have a certain number of individual slots. More slots would mean more funding is needed. Allison Davenport clearly knows this program, which is why the advocacy is going to be really important. We have not seen states come out with here's what we're going for under this program yet. It's really in the place where you can influence it because it's in the infancy stages here. That's why we wanted to get this webinar out now. But yes, states are going to have to come up with their portion of the state budget. And many of them will be looking at getting people out of institutional settings because institutional settings are very expensive from a state budget perspective. Gwendolyn says, I think Maryland is 1915 I and C. I bet Maryland has good. I don't know Maryland well enough to answer that question. Maryland is covering housing support services via an 1115 waiver called ACES, Access to Community Supports. Give me 2 seconds and I'm going to go on Google. I'm going to get you exactly what that program is called in Maryland, Gwendolyn. It is the Assistance in Community Integration Services, ACIS, Assistance in Community Integration Services. So they do cover tenancy supports via an 1115 waiver, but again, there has to be person-centered planning, there has to be conflict-free case management. All the things that are in HCBS, they're in there too. So I hope that's helpful. Margaret, you're welcome. I'm just going down my Q&A list. Ohio is also great. State-specific advice for Ohio is reach out to your local CSH office. Leo Werner, Terry Power, they are very much working on trying to get Ohio to cover home and community. I'm sorry, getting Ohio to cover housing and housing support services. And Danielle asked, oh, Claire Gregory's on here. Thank you, Claire. If I had just kept going down my list, I would not have to Google that. I would have told you, go talk to Claire Gregory. She runs this program in Maryland and she's awesome. Okay. And she said what I said, which is good. It must be right if Claire agrees. They do have C and I programs, but ACES is what is within at 1115. Thank you, Claire. Danielle Levivre asks, is there contact info for the folks in Washington so we can get data? Aubrey, do you want to jump off and see, is there more there? What should I answer? I don't know if Aubrey's still with us.
I am. I'm sorry. I didn't
There was
follow
one in
exact.
contact info. Somebody in the Q&A is
Oh,
asking for contact info for the folks in Washington.
sure. Can I just type it into the QA? Will that be visible?
Can you see Danielle Rivre, Riviere? Danielle, forgive me. I'm sure I just butchered your name and I apologize. But if you can type, if I don't know if you can type it in or you wanted to tell me, I know I can type it in. See if you can do it, Aubrey.
I put it in the Q&A.
We can include it in the, yeah.
If you're
Oh,
sending out,
Aubrey gave it to us too.
yeah, if you're sending out a follow-up to attendees, feel free to include. Right.
Danielle, I don't know what you can see, so Audrey graciously put her email in the chat, and I'm putting it into the Q&A. So thank you, Audrey, for that. I hope, Danielle, you got what you needed, and if you didn't, or how to follow up, excuse me. So yes. Any other questions?
Thanks, everybody.
All right.